A very good evening to one and all present. Today, we'll be dealing with the topic, the vital pulp therapy, which include direct pulp capping and indirect pulp capping. Myself, Dr. Sheena here, endodontist. So today we'll be dealing with the most important topic and most frequently asked question has been seen from this topic also. So I'll be dealing with the classification of the pulp capping and the various materials that is used and what is the difference between each like capping process or procedure and how it is different and what are the terminologies and what are the points that you need to keep in mind while you answer to the question that is being dealt in this topic. So the content is very important. It actually includes the classification. It includes direct pulp capping and indirect pulp capping, the various agents that is used for pulp capping, and mainly the pulpotomy. Pulpotomy is of various types that is based on the material. It is pharmacrosol pulpotomy, partial pulpotomy, complete pulpotomy, and again based on non-pharmaceutical pharmacotherapy, laser-induced, electrosurgical induced, and ferric sulfate. That will be actually dealt in the following PPT. So what is pulp therapy? So in this slide, the main important point that you need to take when the pulp get infected, we normally do a root canal treatment where the pulp become non-vital or the tooth become non-vital. In this procedure, we try to maintain the vitality of the pulp, the treatment, so that there will be certain reparative dentine being formed. As you can see in this image, you can see the caries is actually involving the pulp. So what we'll do a root canal treatment. So why don't we do a procedure? Why don't we do some pulp treatment procedure where the vitality of the pulp is been restored. So in this slide, you can actually the point that you need to take into account is like the third point. What is the primary objective of vital pulp therapy? The vital pulp therapy is mainly done to actually, which helps in the formation of a tertiary reparative dentine or calcific bridge formation. So by this, it actually in turn prevents the penetration of the further caries, etc. So how is vital pulp therapy being classified? The vital pulp therapy is classified into pulp capping is of two types, indirect and direct. As the name suggests, indirect pulp capping means the pulp is not exposed. We'll be actually placed in, so think that this is the pulp and we will be placing material that is near to the pulp. There will be small amount of dentine that is actually present on the surface of the pulp that prevent the exposure of the pulp. So what about direct pulp capping? Direct pulp capping is actually a procedure where the pulp is actually exposed. On top of that, we'll be placing the material. As you can see in this image, it consists of actually the coronal pulp in this area. Coronal pulp this is called as actually the radicular pulp. So in pulpotomy, we'll be removing only this area. That is actually called as a coronal pulp will be removed in this case. Now, what is apexogenesis? Apexogenesis, as the name suggests, apex is genesis. Apex is formed. In certain cases, where the pulp is vital, sometimes because of trauma or something, the root apex won't get closed. In those cases, we do a apexogenesis, which will be dealt in the following PPT. So talking about direct pulp capping, as the name suggests, there is direct. We'll be placing the material or the reparative material directly onto the surface of the pulp. That is called as direct pulp capping. So what you need to know is like, as you can see in this image, you can see this is actually the pulp. It is involving the pulp. We'll be placing certain materials or certain medicament on the surface of the pulp that helps in the production of reparative dentine. All right. So this is based on American Academy of Pediatric Dentistry. So what is direct pulp capping? It is a treatment of an exposed vital pulp by sealing it directly onto the surface of the pulp. That helps in the formation of the primary goal, that is a reparative dentine formation. As you can see in this image, the first image shows, you can see the caries or the mechanical injuries are actually placing a hemostatic agent so that the bleeding will be stopped. And on surface of that, we'll be using certain material that helps in the formation of dentine bridge. So this is actually the basic procedure of direct pulp capping, right? So in all cases, we cannot do a direct pulp capping. That is very important to keep in mind. In all cases, we cannot do a direct pulp capping. There are certain objectives according to the American Association of Pediatric Dentistry. That is like why we need to do a direct pulp capping. This is very important to keep in mind because some of the questions that have been asked is actually the option forms. Very important to know the objectives. The first is the tooth vitality should be maintained. So we know that the pulpal vitality or the pulpal, it should be maintained in a vital manner, right? No post-treatment signs or symptoms do a vital pulp capping. We should make sure that once we do vital pulp capping, after we do the treatment, the patient should not have any signs or symptoms. Third, once we place the material, it should heal and it should produce a reparative dentine. And very important, there should not be any radiographic signs or any infection that like abscess or something that is present in radiograph. Very important. And no signs of internal root resorption in the percussion area should be actually noted. So these are the objectives. So what to like keep in mind is like sometimes the question will be like you should read it very carefully, which is not the objective for pulp capping will be the question. So sometimes it will be like there. So what is the indication? In which cases we can actually do a direct pulp capping? As I told, whenever we do a tooth cutting, sometimes because improper cutting can lead to the accidental exposure of the pulp. And it should be less than 1 mm, which is but it is less than 1 millimeter, and it is surrounded by a very clean dentine surrounding the pulp. That is the first indication of direct pulp capping, and all the dentine that is surrounding the accidental pinpoint pulpal exposure should be very clean. That is the first indication. Right. Next is the traumatic fracture of tooth with pinpoint exposure. Sometimes because of trauma, the patient might actually fall and there will be fracture of the crown taking place and there will be exposure. What is the goodness in that case is like the pulp is very virgin. It is not, it is still in a sterile environment means if it is not contaminated means we can do a pulp capping, direct pulp capping. Third is iatrogenic exposure. Whenever we do a crown preparation or a cavity preparation, sometimes the pulp might get exposed, but the pulp will do a direct pulp capping. Normal vitality test without tenderness to percussion. If there is percussion test positive, that means that in those cases, we cannot do a pulp capping. Sign should be proper. And next is young patient. So that the pulp capping is mainly indicated in young patients. That is because the pulp is very much like it is having a lot of blood supply. It is very much high. Pulp counts are very high. So those are some of the supportive factor why we should do this kind of pulp capping in young patients. Next is the contraindication. So, of course, you might be knowing if pain is there, we cannot do. If the tooth is mobile, we cannot do. If the periodontal is showing some kind of widening, we cannot do. If in the radiograph there is any radiolucency, changes like the internal or external resorption, we cannot do. Sometimes there might be swelling or fistula that is associated with the tooth. And all those pathological condition, we cannot do a pulp capping. Please keep in mind. So we know that what is the procedure normally, as you can see in this image, there is a very 1 mm and all the dentin very clean. So please, cavity should be cleaned with sterile saline or a distilled water or chlorhexidine. Please keep it. And we know that the bleeding is there in 1 mm of diameter. So use some hemorrhage is being arrested, as you can see in this image. And afterwards, once the bleeding is stopped, we can actually place some medicament. You can see here, some pulp capping medicament is placed on the surface of the exposed pulp. Why we are actually using this? And please note, with so as to avoid forcing the material into pulp chamber. Again, one of the questions like, what are the steps in like in direct pulp capping? So you might like not read this area. Avoid forcing. Sometimes the question in the option will be like, we'll be placing the pulp capping material with a lot of force. So whenever you read the question might be very easy. It is only our conscious reading or concentration where we can actually provide a proper answer. So that is very important. And at last, we need to actually produce or place a temporary restoration and leave the called back, and we have to check that the dentinal ridge formation have taken place or not, etc. has to be checked, and see whether the patient is not having any pain or any symptoms. The vitality of the pulp is still maintained. That is the most important like aim of pulp capping along with the tertiary dentine formation. So what is the success of or the factors affecting the success of direct pulp capping? The size of the exposure. Larger exposure, we cannot do a vital pulp capping because we cannot control the hemorrhage and vascularity of the pulp, as I told, like it is very much associated or used in young patients. And it should be very sterile condition, rather mostly the pulpal floor on the top, not the other walls, axial walls, etc. So these are the factors that help in the success of a direct pulp capping. Next is indirect pulp capping. As the name suggests, as you can see in this image, here the pulp and the cavity is having a small amount of dentine in between that. That means that the pulp is not exposed. That might be caries dentine. We have to make sure that the dentine that sits on the surface of the pulp should be a affected dentine, not an infected dentine. Because infected dentine is made up of microorganisms. So we have to remove that. And once we reach a dentine which is very much on the surface of pulp, not exposing the pulp, and on the surface of that, we will be placing a medicament that helps in the recovery of the pulp. So this is indirect pulp capping. Here you need to keep in mind, pulp is not exposed. A small amount of dentine is placed on the surface of the pulp. Very important. This lesion which is close to but not involving the pulp. That is a very important point that you need to keep in mind. It is not involving the pulp. Second, in a very vital primary or young permanent teeth, we can do pulpal inflammation adjusted to the minimal. That means that there should be no periapical change. There should be no radiographic change. There should be no signs from the patient saying that he is having a pain during chewing, like dull aching pain. The symptoms of pain should not be there, or patient should not say that he had or she had pain something. She should not say. That is the indication of a indirect pulp capping. Now, clinical examination, when we do, there should be no gingival periapical changes, no normal lamina dura, there should be no focal involvement. All the area should be properly been seen. That indicate that the actually made. Now, what is it? As I told, like if the patient is having some sort of pain, like a prolonged night pain or discoloration of the tooth showing that necrosis of the pulp, mobility of the teeth, negative reaction to electrical pulp testing means the pulp is non-vital, and all pulpal and periapical signs and interrupted. As I told in the last slide, if any this signs or symptoms is actually seen, it is a contraindication to do a pulp capping. That is very important. Now, what are the objectives? As I told, objectives you need to keep it because to maintain the vitality of the pulp. That is one of the reason. And the restrictive material which we place, it seals the pulp, or it protects the pulp from the oral environment that is present, and to actually avoid the pulp getting necrotized or developing a symptom or sign. And another objective is like to help, as I told, the reparative dentine formation or the remodeling. The pulp should respond favorably, and tertiary reparative dentine should be formed and should be very much evident in the radiograph. That is another important thing. And there should be no evidence of internal resorption. So hope you understood the objectives of both direct and indirect pulp care. It is almost same actually. There should be no pathological changes. There should be no sign. Pulp is exposed either by actually any mechanical injury or during ground preparation, etc. And the exposure should be very much less than 1 mm, and it should have a sterile dentine that is present around the exposed pulp. While the case of these, here no present on the surface of the pulp, preventing it from the exposure of the pulp and helps in the formation of reparative dentine. So what is the treatment procedure? Again, it is almost a very small amount of will be actually placed and or the pulp capping agent especially done. So this is actually the procedure of like indirect pulp capping. So hope you understood. So again, like scooping out of the cavity is mainly done. Sometimes a term will be like scooping out of the small, soft carious lesion from the cavity. That is very important. And once it is actually cleaned, we'll be actually disinfecting that area either with saline or chlorhexidine and etc. And after that, we'll be placing the intracanal medicament, and on top of that, we'll be placing a temporary restoration. So what are the outcome of indirect pulp capping? Once we do indirect pulp capping, what are how pulp capping, which is the type of dentine that is formed? It is cellular fibrillar dentine. Just think it is some fiber-like dentine that is formed. After 2 months, that is approaching the third month, it is globular dentine that is actually formed. And when we actually reach the tubular dentine is actually formed further. And after 3 months, 0.1 mm is actually formed or laid down. So this is very important. Another important question is being asked from the pulp capping is Dical. Dical is actually calcium hydroxide. Dical, sometimes the question will be how Dical is being present. Dical is normally supplied in a two-paste system. It contains one brown paste and it contains one white paste, and we'll be mixing that and we'll be placing it, or the mixing will be done within the cavity because it sets very fast. So one paste will be placed. Cellular fibrillar dentine is formed. Within 3 months, globular dentine is formed. And after that, 0.1 mm of dentine is laid down. That is very important, and which is the most commonly used material. Pulp capping agent. So talking about pulp capping agent, we know that first of all, calcium hydroxide, so this is again another question. So the question might be like, which of the following is not a pulp capping agent that is actually used? So you need to know which are the commonly used pulp capping hydroxide. And again, zinc oxide usually, you might get confused if you see zinc oxide usually. Oxide is also used as a pulp capping agent. Very important. MTA, we know that mineral trioxide aggregate is also used as a pulp capping agent. And growth factors, because when we place this growth factors, they actually activate and actually forming the reparative dentine, etc. And other type of it is not much used, but it has been actually studied. Antibiotics, polycarboxylate cement, inert materials, collagen fibers, formicrosol, and bonding agent. So these materials also actually prevent the further infiltration of the toxic substances into the pulp, and the vitality of the pulp is actually maintained. So this is question: which of the following material is the most ideal for indirect pulp capping? So we know, like we already know, the calcium hydroxide is the most commonly or widely used material for indirect pulp capping. So some of the important points that I've discussed here is or some of the points that is again and again been asked for the exam point of view. Who is the founder or who introduced calcium hydroxide? So calcium hydroxide was introduced by Hermann. That is very important point that you need to know. So why it is widely used is, that is mainly because it helps in the production of reparative dentine, and which was actually found out in 1938. That is why it is calcium hydroxide is considered as the gold standard material for pulp capping. So what happens is again, some of the things that you need to know during how is the mechanism through which they helps in the formation of this reparative dentine. The first is they stimulate the reparative dentine formation. Very important. How? Because of the high alkalinity, we know that it is CaOH twice. So it disintegrates to produce calcium. This leads to this enzyme help in actually the formation of dentinal bridge. So please keep in mind. And what happens is when calcium hydroxide is actually applied to the pulp tissue, there is necrosis of the adjacent tissues that take place. And that what type of necrosis? This is another question that has been asked. What is a type of necrosis that is produced by calcium hydroxide when it is actually placed on the pulpal tissue? It is liquefactive necrosis that is actually produced. So what happens is because of liquefactive necrosis, it actually attracts the osteoblast, etc., that helps in the formation of dentine. That is very important thing that you have to keep in mind. So what is the advantage of calcium hydroxide? We know that it is having an antibacterial property because of its alkaline nature. It had the reparated dendrine formation because of the activation of alkaline phosphatase. They helps in the pulpal protection, and it had tissue dissolving property. One of the most important disadvantage of pulp capping agent is tunnel defect. Tunnel defect means what happens is like the dentine that is formed is not actually uniform. So that is one of the most important problem with calcium hydroxide, and why we are searching for a newer material for like pulp capping agent. So this is actually healing of pulp take place once we place calcium hydroxide. There are four zones which is very distinct that is formed. First is zone of obliteration, zone of coagulation, zone of dentinal bridge formation, and line of demarcation. OCDL. I should memorize this OCD. We know that OC obliteration O. C is zone of coagulation formation. The last one is the line of D or the healing, how we actually see once we place the calcium hydroxide. So this is actually image. Normally, another important thing that you have to keep in mind is like how much time does it take to form the osteodendron? There are a lot of articles or a lot of references saying each time, but the thing that you have to mark in the like answer paper, it is like 6 to 8 weeks. The calcium hydroxide, it takes about 6 to 8 weeks for its reparative dentin formation. Please do keep in mind. This is another important question. Next is I have added a very small thing about MTA, because again MTA is being asked like what is a ratio, how it is, that is being asked from MTA. So mineral trioxide aggregate was actually found by Mohammed Chorabin Jad in 1993 in the Loma Linda University. Just memorize who it is. Mohammed Chorabin Jad actually is actually mixed. It is 3:1. Very important. The ratio, how it is mixed, is 3:1 ratio. And what is a pH? That is very important. After 3 hours, the pH changes to 12.5. That is very important again. And MT is available in two types, gray and white. Gray is actually mainly because of the presence of ferric sulfate. Ferric iron is actually present. That is why it is having a like gray color. So please keep in mind all these important points. Two types, gray and white. The ratio is 3:1. The pH changes from 10.2 to 12.5, and the mixing time is very important. It should not be less than 4 minutes. Okay. Having a problem called as tunnel defect formation. So, or what happens is like when we actually use calcium hydroxide, it is not homogeneous. We know that calcium, we use chalk. When we put chalk in water, it dissolves. Similar as calcium hydroxide. When it comes in contact with actually the water or any moisture environment, there is chance of the disintegration. Trioxide aggregate sits in the presence of moisture. That is why MT is very famous nowadays, because it is hydrophilic in nature. So it sets in the presence of the blood or the moisture where we place, right? And another important, so that we have to wait for a longer period of time for its like setting to take place. So that is why we actually went to the raw material, biodentine, which is having similar properties, is hydrophilic, It is having similar properties that MTA, but the one difference is like it sets at very small amount of time. Apical plug formation. It is used in the repair of fractured tooth, furcal restoration, etc. It is being used. Right. So composition, what you need to know is like mainly they include the tricalcium silicate. That is a point that you have to keep in mind. It includes tricalcium silicate, tricalcium aluminate, tricalcium oxide, silicon oxide, etc. So these are the most important thing that you have to keep in mind. Just a silicate cement, it's a silicate cement. And what is the difference between gray MTA and white MTA? You can see in the first line, gray MTA contain ferrite. Please keep in mind, ferrite is a component, or tetracalcium aluminum ferrite is a component that is actually responsible for causing the discoloration. So as I told, you need not study all the advantage, disadvantage, just go through the pulp capping agent, because the question has been asked, which is not a pulp capping agent, which is that carbon dioxide lasers, very important. Lasers have been actually used for bringing about that hemorrhage control, etc. GIC, MTA, growth factors, etc. Now, very important topic, pulpotomy. There are two. So direct pulp will be exposed, indirect pulp won't be exposed. Pulpotomy, pulpectomy. Pulpotomy means when the infection, as you can see in this image, when the infection is involving only the coronal portion of the pulp, pulpotomy, we will be removing the coronal portion of the pulp. That is called as pulpotomy. So pulpotomy is a very widely used technique in young permanent tooth. That is very important. Where coronal pulp is actually removed and the lower pulp, that is the radicular pulp, is kept as right, which helps in actually promote the healing. So the vitality of the tooth is kept as such, and in turn they helps in the formation of the dentine bridge. So you can see in the image there is a red color showing in that is actually the radicular pulp. The pulp over here is removed. Okay. That is called as actually pulpotomy, where the pulp of the coronal aspect is actually removed and the radicular pulp is kept as indications. So, pulpotomy, care is exposed primary teeth, and there should not be any periapical change. What do you mean by periapical? If there is periapical change, the infection from the coronal pulp have moved into the third of the root line should be there. That is because we know that the primary tooth undergo resorption when the permanent tooth come in beyond that. So when it is indicated as like the root length, right? And it is actually used in young permanent teeth. So this is